Good morning, and depending where you are in the world, good afternoon, good evening. Hope you are all doing well and in good health. My name is Rita Badiani, and I'm the director of the Evidence to Action project, Each Way, which is USAID global flagship for strengthening family planning and reproductive health service delivery. Each Way is also the secretariat of the Method of Choice Community of Practice. In the behalf of the TAG members of the Method of Choice COP, this thriving community of experts, I want to thank you for sharing your time with us today. We are about to discuss two important areas for ensuring women and couples can make decisions about contraception that are voluntary, client-centered, informed, and supported. Method of choice and self-care. And we have a lot to discuss on this topic today, so there is really no time to waste. It is my pleasure to introduce Each Way's technical director, Eric Ramirez Ferreiro, who will moderate today's event. Eric, over to you.
Great, thank you, Rita, and welcome to everyone. Quickly, to get us started, we're going to review the goals of today's meeting, the agenda, and just a couple of quick housekeeping things. First, our goals are to learn more about the concepts of self-care and method choice, especially how they intersect, hear from experts and implementers with concrete examples from their work in Benin, Niger, and Rwanda, and discover recent innovations in products and practices that enable women and girls to have more active participation in their health. So to briefly review our agenda, we'll have some opening remarks first from Trish McDonald from USAID, and then we'll go on to our presentations, which include Martha Brady from PATH presenting on reimagining method choice in the era of self-care. Doreen Irankunda from PSI will do an introduction of the Caya Diaphragm in Benin and Niger. And Natasha Mugeni from Kasha Global will do a presentation on a private sector approach to self-care and method choice in East Africa. Following this, we'll have a Q&A session. And regarding that, just a couple of things. Given the large number of people on today's call, we have muted all participants. However, we do encourage your participation. So throughout the event, please share your questions and comments by clicking on the Q&A icon, and you can see it there on the screen at the bottom of your Zoom screen. So now, without further ado, let's get started. I am very pleased to introduce Patricia McDonald, who's Senior Family Planning and Reproductive Health Technical Advisor in the Office of Population and Reproductive Health, and she's also a Technical Advisor to E2A, who will provide some important and timely context. Over to you, Trish. Welcome.
Thank you, Eric, and I'd like to take this opportunity to welcome everyone to the webinar on Reimagining Method Choice in the Era of Self-Care, which is hosted by the Method Choice Community of Practice. Now more than ever, with the emergence of COVID-19, self-care has become all the more prominent in all aspects of healthcare. For family planning, this has meant looking towards a group of contraceptive methods that are women-controlled or self-administered. We're fortunate to have had so many years of work that have gone into developing these women and couple-controlled and self-administered methods, such as the Caya Diaphragm, the vaginal rings, condoms, and pills, as well as the fertility awareness methods that include standard days methods and lactation amenorrhea method. Likewise, the technology for some of the existing methods has also evolved to become more women-controlled, such as the DMPA sub-Q or Cyanopress, which women in many countries are now able to self-inject. Within the context of self-care, not only can women control or self-administer these methods, the methods can be obtained in a number of ways through different channels and innovative approaches that don't require a visit to a health facility. For some of these methods, like pills, condoms, and DMPA sub-Q, multiple units or packets may be supplied at one time, further reducing the need for multiple contacts. And digital health is becoming both a great resource for information that supports self-care, as well as a contraceptive method through, for example, the digital app for standard-based method. So within the context of self-care, especially in this time of COVID, one might say that women still have a lot of choice of the methods that they use. Next slide. But if we shift the context to method choice and show how self-care fits within that, we come up with a somewhat different perspective, one in which all contraceptive methods have elements of self-care, even if they're not self-administered, but are provider-dependent, such as implants, IUDs, vasectomy, and tubal ligation. In looking at the circle of care, which illustrates the interface between social and behavior change and service delivery before, during, and after a healthcare visit, there are many ways in which self-care can be more clearly defined, enhanced, and supported. For example, for clients who receive a long-acting or permanent method, self-care includes things like wound care and checking IUD strings, as well as managing bleeding changes and taking care when needed, things that clients are asked to do independently after receiving care. Self-care also encourages clients to seek care when needed. In this way, self-care also provides the before services as clients seek information about contraceptive methods, make decisions, and take action to seek care. The during phase of self-care in the circle of care, during a healthcare visit, this can include such things as clients having the self-confidence to ask questions to ensure that they're getting the choice of methods that best fits with their own needs. Self-care also challenges the health system and healthcare providers to make a shift in their interactions and counseling with clients in ways that strengthen clients' sense of agency, self-efficacy, self-confidence, and a feeling of empowerment. Self-care is emerging and evolving. It's an emerging and evolving dimension of healthcare. Likewise, our field of method choice also continues to evolve. So going forward, we need to continue seeking ways that full method choice are always available and in ways that enhance self-care and self-efficacy in a client's sense of agency and empowerment. So we still have work to do going forward. Thank you. Back to you, Eric.
Great, thank you, Trish. Before we move on to the next panelist, just a reminder to submit your questions or comments by clicking the Q&A icon at the bottom of your Zoom screen. Next up, we're very pleased to have Martha Brady join us, who's Director of Sexual and Reproductive Health at PATH, who will leverage her work leading a global team of researchers and implementers to share the latest on self-care products and practices. Welcome, Martha.
Thanks very much, Eric, for that kind introduction. And thank you for inviting me to participate in this very exciting webinar. You'll note my talk is Reimagining Contraceptive Method Choice in the Era of Self-Care. I should begin with definitions, always important to ground ourselves. So there are many different types of definitions out there. I've selected that put forward by WHO. So what is self-care? Self-care is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and to cope with illness and disability with or without the support of healthcare providers. So they're important point words there. And the scope of self-care is quite broad. It includes both health promotion and kind of disease prevention and control, and sort of self-management and self-medication. It also encompasses this notion of providing care to others and seeking appropriate specialist care when needed. And also there's a part of self-care that's about rehabilitation and palliative care. So that's sort of the broad definition of self-care. And I wanted to point to you the recently released WHO Consolidated Guideline on Self-Care Interventions. This was released actually 2 years ago. A number of us probably on this call were part of those guidelines development process. And as you are aware, the WHO guidelines development process is quite a lengthy process of vetting evidence, et cetera, with a group of experts. So there are many areas at WHO and others that are interested in the self-care theme. This particular guidelines really focused it initially on self-care, on reproductive health and rights. So I would, for those who have not seen it, I would urge you to do so. Just note that it was officially launched from WHO globally, and also now is being launched in a number of different countries, working with country ministries and WHO agents, bodies throughout low and middle income countries. Nothing is really new. Self-care is not a new concept, right? Women have been practicing that for millennium through childbirth and through managing pregnancies and managing child and family illnesses. So what is new? And I sort of refer to this as kind of the emerging realities where we are now. And a couple of things I think that are important and noteworthy. First is that we see that there is a growth in both products and platforms making self-care possible for more people and making it healthier and safer. We also see a rapidly changing environment in which there's much more consumer-driven healthcare. And that's true not only in the West, but it's true increasingly throughout many of the low and middle income countries in which we work. Self-care has become much more sophisticated and data-driven, so you can have much more specialized and individualized medicine and specific information about your own health and your healthcare needs, and that will just, I believe, continue. We are seeing increasingly important connections between digital applications to support self-care. So digital can help individuals find information, assess knowledge and resources, and figure out how to do both how to basically engage with self-care products as well as practices. I think it's important to recognize there are self-care practices in addition to just sort of products and technologies. And then finally, evidence is pretty strong. The evidence is clear that when people are active participants in their healthcare, that their outcomes improve. And that's true across many areas of health. It's particularly been quite strong in the areas of NCDs, and most notably with diabetes and hypertension. We know that the outcomes are directly related to how well individuals do what's considered self-management. And so that is part of self-care, and we see in that space those outcomes are actually clearly improved. I'm going to focus our attention now on a couple of examples from across what we refer to as the 4 Ds: drugs, devices, diagnostics, and digital. I'm going to now turn our attention more focused to SRH products and practices. Here you see a large and long list. I won't read them all off, but I did want to give you a sense of the array. We begin with the self-administration of injectable contraception, the HPV self-sampling for cervical cancer screening, over-the-counter provision of oral contraceptive pills, interestingly, home use of ovulation prediction kits, or OPKs, for fertility management, and I've also included self-collection of samples for STI testing. You'll note that those first 5 that I just read off have a little asterisk, and that connotes that those are the WHO recommendations, new recommendations developed for this guideline. So those have all been vetted with evidence, et cetera, for their role as a self-care intervention. Beyond those, we also note HIV self-testing. It's very, very increasingly common and important. Emergency contraception, pericoital or on-demand contraception, all of that fits under this category. Barrier contraception, including diaphragms and condoms, I think you'll hear more about that later. Also included is the contraceptive vaginal ring, relatively, the past 2 years or so, been approved. We note fertility awareness mobile apps, pregnancy test kits, and then there's a whole range of menstrual management and hygiene supplies. All of these, there's probably more, but these are the most frequently discussed self-care products currently available. Next, I wanted to take us a little bit through, now that we've gone through some of the examples of methods and products, wanted to go through a bit about applying the self-care lens to women. I'm going to focus mostly on women's health and what we've been learning. And this learning has been in the past few years as this field has really started accelerating. The first is that the concept and practice of self-care is actually appealing to many women. When it first discussed and kind of described what it is, it's very appealing to many women, particularly young women. We see this in a number of ways. Particularly, we've seen this in the contraceptive self-injection space, where 25%, even higher in some countries, it's young women who are asking to try the self-injection. I was giving a talk at one point in the U.S. some years ago, and some young woman asked me about PATS. DIY contraception is what they call it, so the do it yourself. And I think there's something about that is appealing. We know that self-care to access products and services requires knowledge and the ability to assess and use resources. And here I would just make an important point that I believe reproductive health literacy is absolutely key and is fundamental. Without a good sense of what it is you need, it's very hard to employ, I think, self-care in a positive way. We know that self-care can be rights affirming and very empowering for people, for women in particular, that it has this potential to increase autonomy and agency. And importantly, I think this is very important from a health system perspective, we see self-care as the ultimate really in task shifting. We speak a lot about task shifting in our current work in family planning, and how bumping down the provider of a service to the lowest level cadre that's technically skilled to do that has been a kind of something that people have been trying to reach for, going down from nurses to community health workers, etc. And so this is the ultimate task shifting, where the task is done by the actual user. I think there will be there's discussion around that, and that will continue to play an important role in how we talk about it and how governments and agencies think about it. And lastly, I would just like to say that although we don't have strong evidence of this yet, I do think that offers potential ways to link to primary health care. We see self-care as one step in that it's not a separate entity per se, that it needs to be linked particularly to primary health care. Next slide. Continuing on this notion of research and learning agenda, I did want to just highlight for you the learning agenda themes that were identified by the Self-Care Trailblazers group. I will speak a little bit more about that group, but through a process, both global and country process of consultation, sort of 4 broad themes were identified as needing more research and evidence. And this constitutes some of the learning agenda. There's 4 themes here. The first relates to the individuals, so the individuals in the sense of agency and empowerment, and how can we get good metrics around that vis-a-vis self-care. The second relates to provider behavior and practices to self-care, and I think this is really important. There are many providers who are actually quite sort of a bit resistant to this concept of self-care for many reasons, but one of which I think is that it shifts the locus of control from them to the users, which many are uncomfortable with, either for reasons of kind of hierarchy, but also I think they have concerns about quality, what their role is, etc. So I think that's an important space to watch going forward, because without providers' buy-in and ministries' buy-in that this is additive, I think it will be hard to make headway in some places. The third theme relates to health system shifts to advance self-care. So this is just, again, this is a work in progress, and you won't really see these health system shifts until some years fold. But how, the notion is that self-care will be actually an added value to the health system. It will lessen burden. It will lessen the burden of health providers by shifting that burden, if you like, to end users. I think there's research around this to explore this further. And then finally is around cost effectiveness, quality, those types of elements that are essential to find out when you start any type of, I don't want to call it just an initiative, but new area of work. These are kind of fundamental topics that you want to explore. And these are now just being shaped and formed and underway. Some of these themes are being addressed in some countries by different agencies, many probably on this call today. So now I'd like to drill us down a little bit further into our topic today, which is method choice, contraceptive method choice, and self-care, and what do we know about it, and what are some of the insights and lessons. And here I would say, I think this is a great opportunity where we need to learn, because I don't think we know enough about this. But two reasons. One is I think the self-care agenda and field is moving quickly now, but it's only been in existence for, in terms of programming, I would say, for 2 years. So it's hard to know what effect it has on things yet. So first, a couple of questions, and there are many. I just came up with these that I think are important. So how does self-care affect contraceptive method choice? What do we know about that? Do we see different methods being chosen? What do we know about then contraceptive method uptake and continuation? I think all of those will be important for us to learn about. Do women and or men make different contraceptive choices within the context of self-care? Do we see a shift in how they choose and what they choose? Do we see if we do see that, does that end in greater user satisfaction, which presumably can lead into continuation? We don't know at this stage. What are the opportunities and the risks associated with self-care in terms of quality, cost, and equity? And I think these are things that we need to look at across the whole self-care spectrum, not just contraception, but those are broader concepts, but I think they're relevant here. And just I've added this last one just because I think there's movement now to look at packages of self-care interventions in different countries. So what might a package of self-care interventions look like, and how do you evaluate that? These are some questions, and I have to say that we don't know the answers to these at the moment. We are seeing, at least I can say that we are seeing increasing interest in contraceptive self-injection across the board, both with younger women and older women in their reproductive years. That I think that there's many reasons for that, and the self-care agenda helps, I think, further that or bolster that. And so I'll just leave with a couple more thoughts here, and we'll, I'm sure, have opportunity to discuss later. I think it's an opportune time to explore the role of self-care in method mix. As I mentioned, those are sub-questions, but a couple things that I think are important to mention here is that right now we see an elevated interest in self-care and in this concept of task shifting. That has been risen to a high level, and this is particularly important during the pandemic. Unfortunately, the COVID pandemic has, in fact, I think, served as an accelerator to self-care. People are increasingly using whatever strategies, whether that be telemedicine, digital applications, et cetera, to kind of find their way into health and health care across the board, and including in contraception. Also, self-care at the moment is being positioned as a key component of achieving universal health coverage. So I think that is also something to link to. And I believe that self-care has the potential, really, to transform access. That there are kind of new service delivery models and different kind of financing and governance structures. I mean, I think to me that's, this is a work in progress, but I think those elements are really important and for us to follow. And then finally, I'd like to make this point about, well, when the self-care kind of work began, the overall, greater health equity was kind of the uber goal of that this would expand access and provide more equity, et cetera. And while we want that to be the case, it's not a given. I mean, it may be, in fact, that more advantaged communities are able to have self-care practices or than more marginalized. Although the goal is like self-care can actually work in places where there is no doctor, so to speak. So the notion that it can actually really be more broadly applicable, I think, is the inspiration for it. I see self-care as both sort of person-centered but system-linked, right? So you want to be connected, but not, but having autonomy and agency. I did want to come back to this point. I mentioned it earlier, the self-care trailblazers group. So I want to go through a couple points that I thought would be useful for this audience who may not have been in quite as deep in self-care as some of those on the call are. And I sort of call this the current happenings in self-care. So I've mentioned the WHO guidelines. And then the Self-Care Trailblazers group, it's a coalition of members of wide-ranging organizations, global and global South organizations. At the moment, it is the secretariat is hosted by PSI, and there's several different work streams in this Trailblazers group. And basically, it's tasked with sort of setting, kind of helping shape, I would say, the research, advocacy, and action agenda around self-care. And there are I'm going to highlight three elements which I think are really important that are underway at the moment. Is a quality of care framework for self-care. There's a digital and self-care framework, and then there's this evidence and learning working group. There's many other streams of work, and I can't go into all of them, but I wanted to just highlight them because I think they're particularly important and particularly relevant to this discussion around contraceptive method choice. So again, you'll hear more, I think, in a next speaker about the quality of care framework and some of this other work. Just to note that there have been many country-level advocacy and stakeholder mapping activities, and there's convenings. To date, they've been in Kenya, Nigeria, Uganda, Senegal, and Zambia. I think there are others planned. Just from my side, PATH is working extensively with the Ministry of Health on, and is actually a key country that is doing work on self-care and have set up a self-care pioneers. They're not calling it trail, but it's a self-care pioneers group. So I think that body of work will continue this next year a lot. There have been many resources and tools developed, and if you go to the Self-Care Trailblazers group website, which I'm sorry, I realized I should have put their link in here. You can find many of those. And then just to note, there have been numerous publications and blogs and panels around self-care, contraception, on HIV and cervical cancer. We and many others have been engaged in those. There's been conversations since ICFP in Rwanda to Women Deliver to all sorts of others. I'm sure this will be on the agenda for the FP 2021 meetings. So just to note that is the current happenings. I'd like to end with sort of a final thought, links back to some of our earlier conversations, and that is self-care is more than just products and technologies and interventions. It's an approach, sort of a practice, and a growing movement. The self-care movement is building, and I think this provides a really great opportunity for the method choice and the self-care communities to work together. Thank you.
Thank you so much, Martha, for laying the foundation for us and also for linking us to all of those great resources. For those of you who have joined us recently, just a reminder that you can submit your questions under the Q&A icon that's at the bottom of your Zoom screen. And I also noticed that people are submitting questions in the chat box, which is perfectly fine. We'll be monitoring both. Okay, next, we're very happy to introduce Dr. Doreen Irangunda, who is clinical advisor at PSI, who will discuss the introduction of the Caya Diaphragm in Benin and Niger, which is guided by a quality of care approach to self-care. The floor is yours, Doreen. Welcome.
Thank you, Eric. Good morning or good afternoon, everyone. And thank you to the E2Y project for this opportunity to learn and share learnings. I'm going to talk about the introduction of Caya Diaphragm in Niger and Benin as one of available self-initiated contraceptive methods, and I will elaborate more on the quality of care component. The introduction is at different stages in these two countries, Niger and Benin. While we are just starting in Benin, we are at the learning stage in Niger, and we are using lessons learned for Benin introduction. So you will hear a lot from Niger experience. So without further delay, let's dive in. This is the new quality of care diagram for self-care interventions. Before we go into specific experience with the Caya Diaphragm in Niger and Benin, I wanted to share the new quality of care for self-care interventions diagram and framework. So this is the diagram. As self-care becomes more prevalent and accessible, and with the COVID-19 pandemic acting as a catalyst for self-managing health, quality of care in all self-care interventions must be ensured. Quality of care systems must adapt to recognize an individual's engagement in their own care while ensuring quality, equity, and accountability. So how to do that? How to ensure quality of care in all self-care interventions? How can we use quality of care as a force for good, but at the same time not use it as an excuse to overregulate self-care? How should the health system monitor and support the care a client is accessing on their own while ensuring its approach does not inadvertently hinder a person's ability? Having at heart all these points of reflection and so many others not mentioned here, the Self-Care Trailblazers Working Group developed and shared a new quality of care framework for self-care to help health system monitor and support clients accessing healthcare on their own. Adapted from the Bruce Jane Family Planning Quality of Care Framework, the quality of care for self-care include the 5 domains, as you can see on the slide, and 41 standards that can be applied to a broad range of primary healthcare approaches to self-care. The quality of care diagram and framework for self-care goes beyond evaluating provider and facility quality of care and moves the focus to elements critical for quality of care specific to self-care. Those are, for example, healthcare clients, digital technologies and platforms, regulated quality product and interventions, the trained health workforce, and health sector accountability. These elements were selected from the WHO conceptual framework for self-care interventions. So this presentation contains link of where you can find those tools for your own exploration. Now let us talk about Caya Diaphragm. So this slide shows the Caya Diaphragm features. You may be familiar with diaphragms in general, but I think the Caya Diaphragm may be new to some of you. So the Caya Diaphragm is a newly designed version of the diaphragm. It's a device and not a product. It's a non-hormonal, discrete, on-demand, woman-initiated, and reusable barrier method of contraception. Unlike traditional diaphragm that come in multiple sizes, the Caya diaphragm is a one-size-fits-most device. This makes Caya easy to supply and provide, eliminating the need for procurement of multiple sizes of diaphragms and a provider fitting before use. So the product comes in the form of a thin contraceptive cup that fits over the cervix to prevent sperm from entering the uterus. With support from USAID, PATH and its partners developed the Caya diaphragm through an iterative human-centered design process, which led to several design features that make Caya easy to use, especially for new users, and comfortable for both partners. To use the Caya diaphragm, women apply a small, amount of gel, such as a Caya gel, to the rim of the diaphragm. The Caya diaphragm can be inserted into the vagina anytime before sex, but should remain in place for 6 or more hours following sexual activity. So in Niger, Caya diaphragm was presented with its Caya gel. In Benin, the diaphragm will be presented in tandem with psychobit in some settings. In those settings, counseling will include information that women could use psychobit as a primary method and use Caya during fertile days. We hope to be able to come back and share learnings from this. So now that we know more about the Caya diaphragm, let's look at the Niger country context, as I hope this will help you understand the position of Caya diaphragm. This data comes from PMA, Performance Monitoring for Action 2020, the 5th round, meaning that the data comes only from Niamey, Niger capital. In the context of the ECO project, this actually gives us a better picture of our clients as this project focuses in the capital. As shown on the left, the method mixed figure, oral contraceptive pills account for almost half of modern FPUs in Niamey, though this share is declining as IUDs, implants, and injectables become more available. And on the right, reasons for non-use of contraception in Niamey are led by a perceived lack of risk or need and unmarried status. Opposition to use and side effects are other major contributors to non-use of family planning. This confers an opportunity for Caya Diaphragm as a non-hormonal device. Here, I wanted to share eco-product introduction stages for those who may not be familiar with it. To introduce new contraceptive methods, the ECO project progresses through 5 stages, some of which occur concurrently. Those stages are regulatory assessment and product registration, consumer and market research, procurement and quality assurance, marketing, distribution, and service delivery, and the last one, monitoring and learning. While for Niger, we are at the last stage on operational research, for Benin, we are at the early stages with procurement. In Benin, Caya Diaphragm device is in the country, and we hope that we will be able to start trainings very soon. So now let's look at Caya Diaphragm distribution channels in Niger. Caya Diaphragm and gel kit can be accessed through the public sector for free, in the private sector where they are sold usually for 500 francs CFA, and through community health workers who can sell or refer clients for the public sector. Satisfied users can provide testimonials during IPC session. So for now, in the COVID-19 pandemic, Caya Diaphragm and gel is free for community health workers in the private sector, that's in order to help the national health system. Caya Diaphragm has been integrated in existing FP options available through counseling and IPC activities. Counseling and IPC does dispel myths about the safety of hormonal method of family planning. As of June 2020, 821 kits have been sold or distributed, and 106 gel resupplies, exceeding the planned target of 800 for the duration of the project. So this slide shows client journey for Caya Diaphragm in Niger, where clients interact with health workers in clinics, private or public, community health workers, and can also be in touch with satisfied users. Mail engagement is compulsory, going from awareness to advocacy. Below you will find a link of the quality of care framework on which I will elaborate more. With this slide, I wanted to show how quality of care must be linked with client journey on every step and through all channels. The Safe Care Quality of Care Framework invites the Safe Care Intervention Project or MOH to think on how they will align with the 41 standards that addresses the 5 quality of care domains, namely technical competency, client safety, information exchange, interpersonal connection, and continuity of care, and how they will verify compliance. These standards are grouped within 3 core elements critical for quality of care in safe care, which are person's health and well-being, place of access, enabling environment, and accountability. So in practical, when thinking about awareness and decision steps, we will be, for example, thinking about information exchange standards. As an example here, I can share the fact that clients must receive comprehensive information that responds to their expressed needs and preferences and include alternative options, etc. We will also be thinking about interpersonal connection standards. As an example, we want clients to be treated with dignity, empathy, and respect during all interactions of their self-managed care experience. When looking at initiation and continuation steps of the client journey, we can also be thinking about technical competency from the client perspective and the provider perspective. Here, as an example, We have, as an example of the standard, we have that health worker exhibits the appropriate level of knowledge and clinical skills needed to effectively transmit information and skills to a client so that they can effectively self-manage their care. We also want clients to be able to demonstrate the knowledge and skills needed to competently self-manage care. So this quality of care framework provides a standardized way to think through quality of care of self-care interventions throughout a client journey. Benin team was able to develop a quality of care plan for the Caya Diaphragm introduction. So this is really to think or the kind of exercise that each country must complete when introducing a new self-care product or digital approach. So now let's look at service delivery quality improvement. As part of the quality improvement process, a mystery client was conducted in Niger. Key findings were, let me share just two. The fact that clients, in some places, clients were not able to practice insertion with pelvic model. This was due to a delay in the procurement, and as a solution, more models were procured. Or the fact that in the public sector, some providers were not able to offer Caya. This was due to the fact that only one provider was trained. And as an action plan, Niger team trained 1 to 2 additional family planning providers per health center. So as key learnings, I selected few of so many learnings that I thought may be more interesting to a broad audience. The first one is on acceptability. So there were a theoretical concern voiced during the formative research that this method might be unacceptable in the Nigerian context. This seemed not to be borne out in practice. The method appears to fill a gap in the market by appealing to women who prefer non-hormonal methods of contraception or want a user-controlled method and or have infrequent sex. The second is the need of ongoing support for users. So using a new self-use method of contraception can be confusing, especially for women unaccustomed to other vaginally inserted products, for example, tampons, menstrual cups, vaginal rings, etc. So a good support system for correct use is an important factor in voluntary and continued use of the method. So community health workers played a bigger role here. The last one is on the community buy-in. Buy-in from key opinion leaders is important for the success of any public health initiative, especially in Niger, considered as a restrictive environment. So now let's look at next steps of the Caya Diaphragm introduction in different countries, in Niger and Benin. So in Niger, there is the operational research. This one began in January 2020. The results and insights gathered from this study will inform the recommendations made to Niger MOH, as well as other countries considering adding the Caya Diaphragm to their national FP method mix. The second one was the scale up in Niger. Depending on the outcomes of the pilot, ECO will engage with the MOH and other partners to discuss potential pathways to scale for the Caya Diaphragm in Niger. For those who may be interested to learn more, there is a program brief disseminated on the introduction of the Caya Diaphragm in Niger, and the link is included in this presentation. And there is the introduction of the Caya Diaphragm in Benin, which is leveraging the lessons learned from utilizing the eco product introduction model in Niger, while also adapting the introduction strategy to best fit within the Benin health system. So I think that this is all I had planned to share. Thank you everyone for listening, and I will be happy to respond to questions if there are any. Eric, over to you. Thank you.
Great. Thank you, Doreen, for that comprehensive presentation and also for giving us some conceptual frameworks for for understanding both self-care and also the process of introduction of a new product. Next, just again, a reminder, we've been getting lots of great questions. Please keep them coming. Next, I'd like to turn it over to Natasha Mugeni, who's health coordinator at Kasha Global in Rwanda, who will share an innovative private sector approach to self-care and method choice in East Africa. Over to you, Natasha.
Thank you, Eric. I'm really glad to be here, to have been given this opportunity to share our work at Kasha. Thank you, everyone, for being here. I'm going to go briefly through what Kasha is and what we do, especially for women in East Africa when it comes to self-care and personal care. And so I'm going to go briefly through it and have a few slides, and I'm sure after this, you're going to be having some few minutes for questions. So Kasha is an online and offline platform, and so it's an online and offline platform for personal health and self-care products. And so online and offline, what it means is that you can use any feature phone to access Kasha. So whether you have internet or not, we do have what you call USSD platform, which is more popular, I think, in sub-Saharan Africa, where people use those platforms either to send money. It's mostly used by telecom, and people can use it, in different activities. So we do have that platform where you can be able to access our products, and so we have different range of products, and we have specific products for self-care, and we also do last mile delivery to different locations in our community. So sometimes urban, other times rural. So we are located in urban and rural, but also peri-urban spaces. We do also provide this rich consumer and market insight, which, because we do have access some information from the consumers, so we have I'll say the capacity to be able to screen into those data and understand more what market wants and what people need. So Kasha started in 2016. I started in Rwanda. Then after 2 years, we expanded also to Kenya. So when we were in Rwanda, we started in Kigali, the capital city, but then we expanded. Now we are in more 5 districts. And in Kenya, we also started in Nairobi, but now we have also expanded to these different spaces outside Nairobi. We hope by the end of maybe few years to come, we'll be able to reach the whole region. So how do people reach to us? How do people access our platforms? As I mentioned a little bit earlier, we use a platform, the USSD platform, which is easier for people with no access to internet. And we do have specific numbers for Rwanda and specific numbers for Kenya for that platforms. And we do have websites. So we do have the Kasha Rwanda website, and we do have the Kasha Kenya website. So maybe to give you a bit of understanding of how these two are kind of different. Yes, of course, there's internet access. To be able to access the website, you have to have internet. But also, when you go to USSD platform, you don't really see the pictures. You only see the list, the categories, and when you enter the category, you can see the list of the products available. But when it comes to the website, you can now see the products, the pictures, some of the description, and so on. So we also do have a mobile platform. So we do have application. So far, we have only Android version. We do have also a call center. So people can call us, people can text, people can WhatsApp, and they can also, sometimes people also do reach us on social media. And of course, when we started, especially for Rwanda, people were more calling because they're like, oh, we don't trust this. How does this work? So they call to understand, and it's, I think, gives a sense of if they think it's legit or not. So people will call more, people we want us to order for them. But now as we as we give the information out, as we show people how to order, now have more people ordering themselves without passing by our call center. So what does Kasha provide? So what we do, we have a range of products. So we have the menstrual care products, we have pharmaceutical products. So in pharmaceutical, we do have, the general over-the-counter medication. Also, we do have medication that require prescription. We do have personal care products. We do have mom and bear and baby care products. We do have beauty and makeup products. We do also offer phone consultation, and this is in partnership with, for Rwanda, we are partnering with Babylon, and so it's a platform that provides phone consultation and prescription when necessary, but also do use nurses and doctors in Kenya. So for the safe care, specifically for safe care, so we do provide sexual and reproductive health services, and these include information but also products. So we do have ovulation test, we do have pregnancy test, the HIV test kit, the family planning / contraceptive products. We do have also phone consultation. So and people do call us and we link them with the doctors and nurses to get information. Sometimes people do those phone consultations and they get prescription and they come back to us. So when it comes to self-care products, so far since we started, these are mostly the popular self products that we have. So there's the menstrual care, and I think this is mostly because we do provide also variety of those or many options when it comes to menstrual care. So we do have the pads, tampons, cups, but especially when it comes to menstrual products. Like for example, in Rwanda, pads are so popular, so people don't like tampons or cups. But when you go to Kenya, it's different. People do use tampons more, so we also see the differences depending on the country. We do have substance lotions, and this mostly they are popular because we do have also variety of them. Also, we do have those that not expensive, so we do have options for everyone. So we cater for everyone. We do have also one of the things that is really popular is the emergency contraceptives here, and these are mostly also because some of the products when you go physically to buy them, there's the stigma associated to them. So people will fear to go and buy an emergency contraceptive in a pharmacy because they feel like, oh, I will be looked in a way, I'll be judged somehow. So they prefer using platform where people cannot see them. And also the condoms, the HIV test kits, and we've been giving the HIV test kits. We first gave them as a trial for free with the partnership with Rwanda Medical Center, which is an implementing organ for the Ministry of Health in Rwanda. Then now we have started to sell them, and they are also very popular. The pregnancy tests are also very popular, and I also think it's the same way that people feel like they need confidentiality. They don't need people to look them in a way, but also they need to access the products with also the information, and that's why I think also Kasha is really popular, and that's why people are using it. Actually, is the ability to be able to get your product wherever you are in the areas, of course, we are covering. The information that we give is, for example, for the emergency contraceptive, we do give you a package, but also we insert an information leaflet where we explain how it works, where we explain that this is an emergency contraceptive, so we shouldn't be using it every day, but also highlighting other alternatives for contraceptives. And also making sure that when you have a problem or when you need to learn more, put some contacts. So we put some contacts for the person, for the consumer to be able to call us so that we can link them to the pharmacist or to the nurse or doctor. Also, the interaction with the provider is really minimal compared to the normal physical retailing. So, and also this comes back to the confidentiality, but also the convenience of the platform. And we do facilitate the interaction when necessary for the consumer with the provider. And this has been really one of the things that women or girls, even boys, we reach out to us and like, I need a phone consultation, I need to talk to someone, but they prefer when people are not seeing, because sometimes they feel more free to share what they're going through or what they need. And as I mentioned a little bit earlier, we do provide information. So we do provide information with the packaging, but also do some live session on Instagram. We do some videos and we post, and most of them are education sessions. And we use also to do the physical ones. So we go to the community. But now with this COVID time, we have also increased the live ones, and people are now taking them up. People are visiting our Instagram page to see what you're posting. So we make sure that advertise it, and people will come and ask questions. And most of them have been really on products like cups, products that we think people also fear, people also don't know much. And also we have done some on SRH in general, family planning, contraceptives, some of the local soaps, and how to do skincare routines, all of that, but also the packaging. And this has been one of the things that people like about us, is that when you see your package is sealed, no one has opened it. So it's really like, people feel like it's confidential because only the person who packaged it will know what is inside, and you who receiving the package. And we do provide the last mile delivery, so we make sure that we deliver to the place depending on where people would like. And we do provide a range of products. We do work with manufacturers, and of course for specific products that is possible. And this gives us also another advantage of having affordable prices, and this helps especially the middle, especially the low and the middle income communities. So we are also considering, so there's some projects we are now working on, and we hope we're going to be implementing them soon. So we are working on introduction of the TMPA self-injection in Kenya, and we are also now in Rwanda. We're working on the home delivery of ARVs with the Rwanda Biomedical Center. We're trying to see if this is something that can be possible, and we're going to start by just 3 health centers. If it works, after some few months, then we can expand. So, for example, for some of the pharmaceutical products, we do make sure that people do know, for example, if something requires a prescription, because it's also important to make sure that people don't misuse, or people have to make sure that they know how to use the medication, all of that. So some products do require prescription, and we make sure that people will send their prescription. So you have to place an order, and we ask you to send the prescription via WhatsApp or email us the prescription. We send it to our pharmacy partner, and then they have to authentify it. Then we'll call you back and confirm if it's authentified, and we can now follow the process and deliver your package. So if you don't have a prescription, sometimes we refer you to the Babylon platform, and we talk to a doctor who will go through and see if you don't need really to go physically to a health facility. Then they will send in an online prescription. So how do we deliver? So we do have different types of delivery options. So we do have direct delivery, so you can choose if you want it to be delivered to your place or wherever you are, which is just for urban only. And what we do is we have also option in that direct delivery. So it might be an emergency delivery, it might be within the hours to come, it might be tomorrow, and the prices also change depending on when you want it. We do also provide for urban and rural places. We do provide cash pickup points, and these are mostly like hair salons, popular shops in the area. And for this specific one, delivery is free, so you don't pay any fee for the delivery. So what we do is we package everything for you, then we leave the package to that place when it's sealed and everything, so no one knows really what inside. Even the person in the shop don't know. It might be a lotion, might be a soap, it might be a condom, an HIV test kit. And we also have the Kasha agents. So these are women. These women are also our kind of mobilization agents. So they do talk about Kasha, they train people how to order, they show people, sometimes they do kind of do marketing of new products. And so when the customers do order, we send the orders to them, packaged and sealed, then they go to it's mostly in their area, so they don't go far. And they do provide the packages to their customers, or customers will come to their places to take them. And most of these women are actually community focused. In Rwanda, they're around, I think, like 40% of them, but I know in Kenya they are more, so they're around like 80% or something. So we use actually, most of them are community focused. Yeah, so thank you so much. I'm looking forward to the questions. Yeah, thank you, everyone.
Great, thank you for that, Natasha. It's a really interesting model, and I know that we've been getting questions about it already. And now it's time to open it up for the question and answer. I know we've gone a little bit over, so if you don't mind, instead of ending at 9:15, we may just end at 9:20, just adding the few minutes that we've lost. So let's get started with the questions. We've gotten a lot of good ones. Martha, here's one that was asked that I'm particularly interested in too, is, how is the interest in self-care by clients, how has that been translated into actions by government in the form of policies? In other words, have there been any policy changes related to self-care?
Hi, Eric, can you hear me?
I can.
Oh, good. All right. I hope everyone else can. Thanks for that. Yeah, I've tried to answer some things as I see them coming up in the chat. A couple things on that front. Again, I tried to mention, while self-care is not a new concept, the actual programming of it is actually relatively new, right? So we have a couple things underway, and there is a whole body of work around advocacy and working with specific countries. I mentioned 5 or 6 or so. There are others, working with ministries of health to help figure out how they're defining self-care in their context and what specific policy asks there are within that. So, for example, a task shifting to women's injecting of contraception. That's a kind of an easy, not easy, but that's a clearer ask. So I think the question of sort of how do individuals wanting to do self-care, how does that mesh with what governments and policies are doing? I would just say that there's increasing work on this, and there's, for example, there are civil society groups engaged in these self-care consultations at different country level. So in short, I think it's a work in progress. And I'll just take this time as well, because I saw other questions about how do you do monitoring, et cetera, around self-care choices, et cetera. Again, I think that's what I was trying to say. I think this is a bold new world. I think there's really ripe opportunities for understanding more of this as we go forward. So I think it's a work in progress. I don't know if that's helpful, but that's what I got for you right now.
Great, thank you, Martha. The next question, I see that Doreen has been exceptionally busy answering a lot of her questions online. But I want to ask this next one to Natasha. It has to do with about, she says, I have a question as to whether there's been any concerns by young people in getting packages delivered. And I'm wondering if they are living in an extended family situation, if it might call more attention, than if they were going to a drug shop. And along with that, Natasha, I was just very interested in who your clients are. Are they younger? Are they older? Are they from all socioeconomic levels?
Thank you, Eric. So actually the packages, I think what we have been trying to include is those places where young people can get services. For example, some of the youth centers are pickup points. And also young people do choose, like they can choose any place. They might choose a place where they can get their products without necessarily being in their homes. And so most of our young people actually do get their packages delivered to their schools, or to the youth centers. So that's one of the things that we have seen. But also sometimes they choose a home where it's maybe their friend's home. So and so they choose differently depending on what they would like. So we have never really had any complaints about that. And for the users, I think when we started, we had mostly women. And also we were looking, especially for the sexual reproductive health products, the capacity for young people to be able to purchase them was somewhere were a little bit expensive compared to the purchasing power of young people. So we have seen also, we have seen a high increase when we partnered with Packard Foundation for the subsidization of products for sexual reproductive health products in Rwanda. So what we did was to have a program where young people will have their own coupon code or promotion code. And we use other young people in the communities, we use the youth centers, we use the youth ambassadors to share the coupon code. And so young people can now order and they only like pay 10%, they pay maybe 20%. We have been learning through the last 2 years to see what is really the purchasing power of young people when it comes to sexual reproductive health products, to be able to, even when we're trying to advocate for these services to be available and to be accessible, we have to kind of have a ground of what we think could be the best prices. So we've been trying to also kind of understand that aspect. So the subsidization program of Packard with Packard Foundation has been really, really key, driving young people to our platforms when it comes to HR products.
Fantastic, thank you, Natasha. And this question actually is probably both to you, Natasha, and to Martha. It really has to do with maybe the challenges, particularly with male partners in relation to self-care. That's the broader question, and and how these have been overcome. And Natasha, to you, do you have male users of your products at Kasha Global? So Martha, maybe starting with you in terms of how do men fit into all of this?
Sorry, I've been talking to myself. I forgot to get myself off mute. How do men fit in? Okay, sorry, let me focus. I mean, men are also users of self-care, or can be. It's not an exclusive domain of women. For example, many men are actually using HIV self-testing, et cetera. So the question is sort of about, is there something different about self-care that men will or will not approve of, or like or dislike? I mean, I think in short, I think there's a body of work that needs to be done that I don't know that's actually underway at the moment to understand how partners of the self-care user think about that. So I think that's an area for future work.
Okay, and Natasha, how about your male users?
So we do have actually quite a number of male users. Most of them do purchase condoms because one of the things also I've seen both in Rwanda and Kenya is that male condoms are the ones popular, so people don't really take up the female condoms. And even when we tried to put them, they were not moving at all. So men do purchase the male condoms, and we have also quite a number of male who purchase lubricants.
Great, thank you. And Doreen, a question for you is, what are the contraindications and side effects of the Caya Diaphragm?
Thank you, Eric. I was happy to see a lot of questions on Caya, and I think it was somehow new for many people. So the Caya Diaphragm is a barrier method, which means there is no hormone in it. So there is really no contraindication and no side effect from it, and it can be used safely for everyone. But we always highlight the fact that it doesn't protect against HIV. So women must be aware of that and use a protection, a condom, if there is a risk for HIV. Yeah, I hope it does respond to you. Mm-hmm.
Thanks, Doreen. And here's a question actually about integration that's kind of interesting. How do we envision that FP self-care can be integrated with other types of self-care for self-care packages? Martha, I think that was directed to you.
Mm-hmm. Yeah, I made that point that there are discussions around self-care packages. Some countries are interested in understanding what that could be. I mean, contraception would clearly be in that package, you know. So again, so much of this depends on how countries articulate self-care in their context. What do they mean by that? What they want to include in that, and what they don't include, and then sort of developing it from there. But contraception would clearly be in part of that a self-care package. In fact, many of the products that I mentioned in that one slide are in fact family planning products. In fact, a lion's share of them actually are, I think. But so yes, it would be part and parcel of a self-care package of interventions. And again, there are others on the phone as well. This is something that the Trailblazers group is discussing and sort of seeing what these packages of self-care interventions might look like. And that will be driven by context. I did want to just make one point while I'm here, I'm glad Doreen mentioned this, but just because Pat actually did develop the Caya Diaphragm, and you know, there are no contraindications, as she mentioned. I mean, people have some allergies to some of the, well, not really actually, so there's no contraindications. And while it doesn't protect against HIV necessarily, it does provide some protection against just in general, some of the bacteria, some of the STIs.
Great, thank you, Martha. And then Natasha, this one's for you. You know, it's interesting that community health workers are the ones that become CASHA agents. Have you found that they leave their roles as community health workers to devote themselves to CASHA more?
Yeah, thank you. So being an agent, especially the bottom of pyramid agent, it's not really a full-time job. So it's more also on commission basis. So these women don't leave the community health worker job. Actually, this is like one of the things that it gives them an opportunity and an advantage to reach more people, because they are also doing some work in the community. So they don't really leave the job. Actually, this is like more of, it's not a full-time job. So they just have a few hours where they can communicate and show people how to use the platform if they need for that.
Great. And so, let me see, I'm struggling between some good questions here. So Martha, maybe back to you. What type of monitoring of clients and evaluating continuation of their choice of method is done? In other words, you know, how are we doing sort of monitoring and evaluation in terms of self-care?
Boy, I'm getting all the questions today. I guess I'll just have to defer again here, because in order to monitor and evaluate clients in self-care, we have to have an active program on that, right? So, and this is actually a very so neophyte stage. So I can't respond necessarily to that other than just to say that I think that having monitoring evaluation built into countries as they go forward with self-care, I think will be important. And there's different stages and level, and I think there's probably some folks from PSI that are on this call as well that may have more insight into specific countries that they've been working in and what they're thinking with you know, monitoring evaluation of self-care interventions. But it's again, I hate to keep saying it is a work in progress though.
Great, thank you, Martha. You know, Natasha, I'm going to take a prerogative and ask my own question here. Is you mentioned sort of, you know, Martha made the comment that, you know, self-care should be linked to systems somehow. And you mentioned pharmacists specifically, you mentioned sort of linking them up to a physician if they needed, you know, a prescription. Do you guys have any other plans to continue that, to expand that connections with systems of healthcare, with clinics and the like? Yeah,
so that is one of the plans that we're now looking in the future, but also now in Kenya, we do have the nurse chat. So we have a nurse in-house. We do also have a contraception tool. So people can actually do, you know, reply to some of the question, and the system will give you some of the recommendation. But also we do have a forum where women can actually go and they discuss about the contraception choices, some of the side effects they encounter, or some of the experience just to share. So that also has been one of the things that for Kenya, we are now actually live for that, but we're gonna to expand even for Rwanda. And yeah, and we've been trying also to make sure that we also for the references, not only for doctors and clinics that are giving services, but also for other people. Sometimes we get called for people who need legal support, and we do refer. So we're also trying to make sure that our reference platform is really, really high. And yeah, I hope I answered your question.
You did, Natasha. Thank you very much. Listen, so I think we're going to wrap it up there. On behalf of E2A and all of our partners in the Method Choice community of practice, I want to thank all of our panelists. You did a great job. And for those of you who joined us today, for your valuable insights and really good questions. This is just the start of the conversation. We will be in touch in the coming days with a recording of today's events, and all of the questions that you've answered will be answered in a document, and we will share all of your questions and all of your answers with you so that you have that as a resource. So now, wherever you are in the world, have a great day, stay safe, and goodbye, and thanks again for your participation. Thanks.
Thank you, bye.
Thank you.
Thank you, everyone. Bye-bye.
Thank you, everyone. Bye-bye.